infants or neonates, and the regional information is very necessary. So regional information like within the zones of the lungs, such things are really becomes important. So the unique respiratory physiology of the neonates are like a structural impairment. First one is structural immaturity. So there are fewer alveoli and lack of collateral ventilation, as we all know. And then the diaphragm is flattened and with the horizontal ribs. So, and the next one is mechanical challenges. These lungs are like the chest wall is like highly compliant. We can see paradoxical breathing in in the neonates, and there is reduced type 1 muscle fibers, which leads to increased respiratory fatigue. And the physiological vulnerabilities are immature respiratory control, that is like central apnea, and the surfactant deficiency, as we see in preterm neonates. So now, what is electrical impedance tomography and how does it help us in monitoring such infants, neonates? So the definition is like it's a non-invasive imaging technique that measures changes in electrical impedance within tissues using surface electrodes. So basically here the electrodes are placed on the chest wall in a belt-like fashion around the chest wall, and the electric current is passed. So that electrical current is picked up by another electrode, and the passing electrode and picking up electrode are termed as pair of electrodes. So with the signal, it is projected over to the screen, and with that we get to identify what is happening inside a lung. So basically, I'll talk about the core principle over here. So for generalization, I would say if air is present, the impedance increases. The impedance to the electric current passing through that air will be increased. And if the fluid or tissue is present, the impedance will be decreased. So depending on the signals picked up, it is displayed on the monitor. As we can see on the image on the right side, it's a gross depiction. So we'll come to it later. So this is basically a depiction like how electrodes are placed around the chest wall. Now, how EIT works. So electrodes are placed around 16 to 32 electrodes are placed circumferentially around the chest wall, and the current injection is done. It's a small, safe alternating currents passed between the electrode pairs, and the voltage is measured from the remaining electrodes, and image reconstruction is done using algorithms, and it is projected on a 2D tomographic screen, and then continuous real-time imaging can be done. This is basically, we can see over here is the how the electrodes are placed around the chest wall and how the image is generated. So the like how it works is basically 5 standardized steps are present here. First is the measurement. So the chest measurement involves placement of equally spaced electrodes around the circumference of the chest in a position that is most sensitive to the event of interest. And then the raw EIT images are generated. This consists of generating EIT images from data obtained over one cycle of current application, which is called as a frame. The number of frames obtained and thus raw EIT images generated per second is the EIT scan rate. And the third one is waveform filtering and region of interest. RO is region of interest selection. The process of digital frequency filtering of EIT waveforms generated from raw EIT images to isolate those representing changes in electrical impedance due to physiological or pathological process of interest from other simultaneously occurring events. For instance, EIT lung region of interest can represent regions of ventilator-related impedance changes separated from changes resulting from cardiac activity or pulmonary circulation. So this is what I meant when we can go inside the lung and we can look at the area in which we are interested. And the next step is functional EIT image creation. This process involves the applying of mathematical operations to a series of raw EIT images and their corresponding pixel waveforms to calculate values that are plotted into EIT images. And finally, the quantitative EIT measure calculation. where we can see the we can see various changes like tidal volume, spatial distribution of ventilation, and regional compliance, etc. So this is basically how the monitor looks, and this gives us a continuous monitoring, bedside monitoring inside NICU, which is non-invasive. This is how image is generated. As we can see grossly the difference between the aerated lung and the unaerated lung on your like right lung, that is the left side of left part of the screen. So there are basically three different types of EIT imaging. One is time difference EIT imaging, which is the most common approach, which measures impedance changes related to the baseline, and it is best for dynamic processes. So used for ventilation and perfusion studies. And then frequency difference EIT, which uses multiple current frequencies. This provides basically absolute resistivity information useful for perfusion studies. And then absolute EIT estimates true tissue resistivity. This is technically complex, and basically it's a research focused. So key EIT measures is basically the ventilation distribution, where the center of ventilation, where we can see the ventral versus dorsal ventilation also, the distribution of ventilation in the different regions of lung basically. Then the global inhomogeneity index, how even and uneven the ventilation is can be seen, and the ventilation ratio similarly. Then lung volume and recruitment. So even this tidal impedance variation, which correlates with the tidal volume, and the silent spaces which are poorly ventilated or over distended areas, and then end expiratory lung impedance changes, which is all these things can be monitored in detail. Then the temporal measures, the regional ventilation delay and regional ventilation delay inhomogeneity. These all can be monitored simultaneously. The clinical applications, feasibility and safety, it has got proven safety. The safety index is extremely high, even in preterm neonates. Extended monitoring can be done over up to a period of 72 hours, which is very feasible. And there is minimal risk for skin irritation, and there is no radiation exposure. Monitoring surfactant therapy. EIT can detect improvements which is not visible on blood gases or on conventional imaging. So before surfactant, the poor dorsal lung aeration, uneven ventilation distribution can be seen, and during administration, real-time monitoring of surfactant distribution can be studied. And after surfactant, improved dorsal lung aeration and ventilation homogeneity. All these things can be studied in detail. Comparing ventilation modes. EIT enables detailed comparison of respiratory support strategies. Basically, CPAP versus HFNC versus nasal high flow. All these things can be studied with this. The function of the lung and how the lung is being recruited basically can be studied. And similarly, the invasive versus non-invasive ventilation, the response of the lung with these things can be studied, and similarly about oscillatory ventilation can be studied. And supportive care practices, these include like endotracheal suctioning, which reveals transient lung volume loss during the procedure, and body position, like prone position increases the dorsal aeration. All these things can be studied by using EIT. And again, the head and neck alignments in a similar fashion can be studied. We can do PEEP titration also with this. So the challenge is basically finding optimal PEEP, which is critical, but it is often difficult. So as we know, low PEEP causes atelectasis, and too high causes overdistension and injuries. So EIT helps us to identify the optimal PEEP by monitoring the recruitment or else the overdistension in real time. So basically, this helps us in rapid diagnosis of lung pathologies. So like pneumothorax, immediate detection of air leak can be done. Lower atelectasis can be seen. Similarly, ET tube malposition as well as congenital lobar emphysema, all these things can be displayed on the screen in real time. the limitation and challenges with EIT is there is a standardization gap as of now because there is lack, since it's in relatively a newer modality, there is lack of standardized protocols across the institutions. Algorithm variability is another challenge, like variable reconstruction of algorithms affect the consistency, and technical artifacts like susceptibility to motion and electrode artifacts are seen over here. And then the spatial resolution, like lower spatial resolution, it has got lower spatial resolution when compared to the CT. And learning curve is interpretation requires training and experience again. Future directions, understanding at birth, the EIT offers unprecedented insights into the critical movement of neonatal transition, which is the lung aeration dynamics during the first few breaths, and then the cry physiology and its effects on lung recruitment can be studied. The real-time monitoring, which is the key important feature of EIT, of the fluid clearance can be done, and then identification of transition difficulties can be seen. And then beyond the lungs, we have the application of EIT in other fields also, like intracranial hemorrhage. And we can do gastric emptying studies and pulmonary, we can study the pulmonary hypertension. And then again, the lung growth and development using this EIT modality. It can be integrated with artificial intelligence, which will further enhance its capabilities. There will be improved image reconstruction. There will be automated artifact removal, and then clinical decision support with AI-guided technology can be done. So the conclusion is electrical impedance tomography is a safe bedside radiation-free tool that provides continuous real-time regional lung function monitoring and holds strong potential for individualized neonatal respiratory care, especially in preterm infants at risk of BPD. And we have absolutely zero radiation exposure. The frame rate is 50 Hertz, which is like real-time continuous imaging. And the monitoring, extended bedside surveillance can be done. So 72 hours of monitoring at a time can be done. The take-home message is continuous bedside radiation-free, easy to use, immediate results, and reliable equipment. And before I wind up, I would like to bring your attention to these slides created by our HOD, Dr. Girish Gupta sir. So basically, I'll run through these things. What is EIT? EIT is basically non-invasive radiation-free bedside imaging of lung ventilation and perfusion using electrical impedance changes. The key advantage is it's a real-time regional lung function monitoring. And primary application is optimizing mechanical ventilation and detecting complications early. And clinical impact is again reduced ventilator-induced lung injury and improved BPD outcomes. And it helps us in detecting the complications early. So the fundamentals are core principle is the air will be having high impedance, blood will be having low impedance, and in between there is lung tissue with medium impedance. The technology, small alternating electrical currents are applied through electrodes placed circumferentially around the chest wall, and voltage measurements are used to reconstruct cross-sectional images. And it will provide us a real-time monitoring, and the safety profile is relatively very high. So the 4-step process is, first one is electrode placement. The 16 to 32 electrodes are positioned circumferentially at the nipple level around the chest wall or at the area of interest. The current is injected sequentially and the voltage is measured with the remaining electrodes, and the image reconstruction is done using algorithms. So electrodes are placed with the belt around at the nipple level.
Dr. Anukul, sorry to disturb you. I'm not sure which slide you are showing. We can just see the take-home message slide still. The slide which came around 4 to 5, 2 to 3 minutes back.
Oh, okay, sir. Okay, sorry. Is it good now, sir?
Yes. Now please go ahead.
So sorry, sir. Yes. So yes, the electrodes are placed at around nipple level, and which are like evenly spaced and at a firm contact with the skin, and and areas should be avoided with excessive ECG electrodes or other monitoring leads. And we should check the contact impedance before the measurement and reposition if the patient moves or the belt shifts. The clinical application in neonatal cases is ventilation monitoring, PEEP optimization, and then perfusion assessment and pneumothorax detection, birth transition, extubation readiness, BPD prediction, and surfactant responses, and many more. So, as we can see this table depicts the comparison with other modalities. As we can see, this table has got like lot of key, key EIT parameters and clinical interpretation. The tidal impedance variation, which represents regional tidal volume distribution, and the clinical uses assess ventilation homogeneity and identify over or under ventilated regions. And the second one is end expiratory lung impedance, which represents functional residual capacity. So the trend is it increases with PEEP and decreases with atelectasis. Global inhomogeneity index, which represents non-uniformity of ventilation. The center for ventilation represents weighted center of tidal volume distribution, and the clinical uses monitor position dependent changes, detect regional pathology. And the regional compliance, local lung elasticity at the different regions can be studied. And the perfusion signal, which represents cardiac related impedance changes. The clinical impact and evidence-based benefit is, it has got a proven clinical benefit with reduced ventilator-induced lung injury, improved BPD outcomes, optimized PEEP selection, earlier complication detection, guided clinical decision-making, and reduced radiation exposure. At present, the limitations and challenges which we face are the spatial resolution. It has got lower anatomical detail compared to CT or radiography. Cannot visualize small airways or specific pathology details. And it has got a single slice imaging. Artifacts need to be improved. And the limited availability, of course, it has got the limited availability and the standardization gap. There is no universal protocols as of now. Future directions is like artificial intelligence integration, machine learning algorithms of automated image interpretation, ventilation optimization, and outcome prediction is a future goal. And 3D volumetric imaging. So then at present we have like 2D tomography. Further, it can be enhanced to 3D imaging, and then we can use it can be developed into portable wireless systems, and then personalized ventilation protocols can be devised with this, and multimodal integration can be done, and again big data and outcome prediction on large scale studies can be done using this. So these are the references. So thank you so much.
Thank you, Dr. Anupul. Definitely a new thing to learn. Now I'll request AGPGI team to please take over. Till SGPGI team shows the presentation, I have one doubt, Dr. Anupul. Is this device available in India? And if yes, what is the cost?
Sir, I've checked the cost in India Mart. It's around 30 lakhs.
30 lakhs, okay. And outside, are they using it for research purposes only, or they have started it to use for clinical management?
So there are certain institutes in Western countries. They are actually using it, but still it's at the institutional levels.
Great, great. Thank you.
Thank you, sir.
AGPGI team.
Good morning, everyone. Dr. Adikul, please stop her screen. Good morning, everyone. Myself, Anbar Sane. Moderator of today's topic is Dr. Akansha ma'am. So I will be discussing on the torpedo trial, that is a targeted oxygen for initial resuscitation of preterm infants with FiO2 of 60% by 30%, a randomized clinical trial. This was a trial which was published in Journal of American Medical Association, which was done by Lee Wei et al. And others. So it was published on December 10, 2025, with impact for factor of the journal is 55. So coming into the background, what is the why this trial is needed? We all know that the optimal concentration of oxygen to initiate respiratory support of preterm infant at birth still remains controversial. So which amount of percentage of oxygen can be used for resuscitation, especially the preterm neonate who need respiratory support at birth? So before 1990s, pure oxygen, that is 100% oxygen, was standard based on the assumption that newborn cardiac respiratory depression was mainly due to hypoxia. So in the 1990s, then come the Sostad and others. They have showed that using air, that is 21% of oxygen instead of 100% oxygen for full term and near full term infants, reduce the time to first breath and oxidative injury without adverse neurodevelopmental outcomes. So they shown that air can be used for resuscitation. So meta-analysis of 5 trials, including a number of 1302 neonates, found reduced mortality with air compared with an FiO2 of 100%. So with this knowledge, in 2006, expert guidelines are suggested using air for full infants, and in 2007, the Australian Resuscitation Council recommended air for all gestational age for resuscitation of those newborns. So in 2010, the international guidelines has recommended adjusting the FiO2 to target the SpO2 from the healthy infant after initiating resuscitation with FiO2 of 21% to 30% and avoiding FiO2 greater than 65%. So this is an various overview on the safest oxygen level to initiate delivery room respiratory support of preterm infants, which is unclear. So as we see from this, the Stockton et al. In 1990s has shown that using air has reduced the death in term in hypoxic babies. So over the years, there are various studies which have been conducted to identify the optimal oxygen concentration for resuscitation of these preterm infants. So Stockton et al. In his 2007 has shown that using air for preterm infant at birth, it reduces the oxidative stress in these newborns. So in OE et al. Again, this was an he has shown that in 2010 to 2017, that is the Torpedo 1 trial, where the oxygenation resuscitation was done with 21% and 100% of oxygen. In this trial, they have shown that with less than 32 weeks of gestation, there was no effect between this 21% and 100%. But in less than 28 weeks, it has shown increased mortality rate when oxygenation with resuscitation was done with FiO2 of 21%. So next comes the net motion trial, which was an individual participant data network meta-analysis. Here the 13 trial was included with 3 oxygenation. They were compared, that is 30%, 60% and 90%, and they've shown that higher oxygenation, that is 100% resuscitation, decrease the death, this risk of death versus other oxygen concentrations. So with this basic idea, I will go in this trial. The few points about the torpedo trial, that is 2017 trial, which was again done by OE et al. It is an RCT comparing 21% versus 100% for initial resuscitation of preterm infants. So their primary outcome was death or disability at 2 years of age. This trial was stopped early because of due to slow enrollment and a clinician reluctance to use FiO2 of 100%, and there was no difference in the primary outcome. What the concern from the study was shown by the exploratory analysis was there is increased mortality in infant less than 29 weeks of gestation when they are associated with 21% with an odds ratio of 3.5. So this trial was concluded early by the Drug and Safety Committee because of increase in the mortality when the neonates were associated with 21% oxygenation. So the study design, this was a randomized clinical parallel two-group superiority trial, which was done in 31 maternity hospitals in 6 countries, 8 in Australia, 13 in India, 1 in Malaysia, 2 in Singapore, 6 in Spain, and 1 in US. So the period of randomization was conducted from September 2018 to 2024, with follow-up expected to close in September 2026. And the study sample was, that is, the newborns who are eligible if they are born at 23 to 28 week of gestation and who are requiring respiratory support at birth. So ethical issues, the parents and guardians were given provided written informed consent, and there was no conflict of interest. Ethical approval was given by the Hunter New England Human Research Ethics Committee, Newcastle, Australia. The CONSA 2010 reporting guidelines were followed. The trial was coordinated by National Health and Medical Research Center Clinical Trial, and it was overseen by the Drug and Safety Monitoring Committee. So research question of this trial. the hypothesis initiating the respiratory support of preterm infant less than 28 week of gestation with a FiO2 of 60%, which was adjusted to target predetermined SpO2 over the first 10 minutes of life will, when compared to a FiO2 of 30%, reduce the primary outcome, that is the death or brain injury at 36 weeks of corrected gestational age, and the secondary outcome being the all-cause mortality and brain injury, and the tertiary outcomes, that is the exploratory outcomes are the time to achieve SpO2 of more than equal to 80%, and the registration outcomes, whether the baby need intubation, chest compression, or need for epinephrine, and common neonatal morbidities and neurodevelopmental impairment at 2 years of age. So the primary outcome being the death or brain injury at 36 weeks of correct post-menstrual age. So by coming into the PICOR, the population is preterm infant, less than 29 week of gestation, requiring respiratory support at birth. The intervention is initiating the registration with the FiO2 of 60% maintained for 5 minutes, and it is titrated using the pulse oximetry to standard SpO2 targets. And the comparator being the FiO2 of 30% for registration. Again, the same protocol was followed for the intervention. Outcome was death or brain injury at 36 weeks of corrected gestational age, and the time was short duration, that is from the delivery room until the neonatal shifted to the NICU. The primary endpoint is at 36 weeks corrected gestational age and planned for long-term follow-up neurodevelopmental assessment at 2 to 3 years of age. So inclusion criteria: live preborn preterm infants, gestational age of less than 29 weeks, who are eligible for active resuscitation at birth, who require respiratory support at birth, either CPAP or ventilation, and who are given parental consent. Exclusion criteria: stillbirths, major congenital anomalies or chromosomal disorders, conditions which are incompatible with survival, infants who are not planned for active care, prior enrollment of a sibling already randomized. So randomization was stratified by site and gestational age and pregnancy using the plex trials, and multiple births were assigned to the same treatment group, and newborns were deemed ineligible for inclusion after randomization if the delivery did not occur by 28 weeks of gestation, or if the parent was transferred to a non-participating hospital before delivery. So trial interventions. What interventions are done for this trial? First one is the delivery room intervention protocol. Eligible live preterm infants was placed in the registration bed after cord clamping. So the registration was either done with 30% or 60%. With the oxygen is blended by using an oxygen blender, and assigned FiO2 was made for first 5 minutes wherever possible to preserve the group separation. FiO2 subsequently adjusted with the increment of 10%, 20% for every 30 to 60 seconds depending upon the target SpO2 being achieved. Oxygen is titrated using the preductal pulse oximeter connected to the right wrist. So next comes the oxygen targeting, masking and ongoing care. The target SpO2 of 80 to 85% at 5 minutes and 85 to 95% at 10 minutes and until NICU admission. Escalation to 100% oxygen was permitted if at any time there was a clinical instability with a heart rate of less than 100 per minute, who need chest compressions, who need epinephrine medications for the registration of this newborn. Parents were masked and families were masked. Delivery room staff cannot be masked because they have to adjust the FiO2 based on the targeting SpO2 requirements, and often the registration measures was done as per the local practice, and FiO2 was titrated during the transfer to maintain SpO2 of 85 to 90% post NICU care at clinician discretion. So the primary outcome was death and brain injury at 36 weeks corrected gestational age, and the brain injury was defined by the neuroimaging. Either it is any grade of interventricular hemorrhage, echo, dense intraparenchymal lesions, preventricular leukomalacia, porencephalexis. All the imaging was reported by radiologists who are masked for the treatment allocation. As key secondary outcomes are all-cause mortality at 36 weeks corrected gestational age and brain injury at 36 weeks corrected gestational age. The exploratory outcomes, which are the outcomes which are not powered but helps in generating the hypothesis. So the predefined exploratory outcomes were SpO2 of less than 80% or more than equal to 80% at 5 minutes of life. Time to achieve the SpO2 of more than equal to 80%. With a heart rate of less than 100 or more than equal to 100 per minute at 5 minutes of life, who requires intubation in the delivery room, Hapgar scores of 1 and 5, and post-hoc exploratory outcomes are use of cardiac massage, epinephrine, change in the effort during the first 10 minutes after birth. Other predefined exploratory outcomes which were not reported in this trial are BPD, ROP, NIC requiring surgery or causing death, late onset sepsis, PDA requiring treatment, duration of hospitalization, survival without major disability at 2 to 3 years of age. So sample size, a total of 1470 newborns, 735 group are needed to detect a difference in the brain injury-free survival from 24 to 32% with a relative risk reduction of 25%, assuming a power of 85% with a 5% significance and 10% non-adherence and clustering from the multiple births. So the sample size assumptions were reviewed at the interim analysis and it was not modified. Statistical analysis was finalized before the data were unblinded. Analysis followed the intention to treat principle and excluded the stillbirths. The primary outcome and secondary outcomes are analyzed with a linear model with a log link, and stratification was done to minimize the baseline imbalance for gestational age and multiple gestations. An exploratory and subgroup analysis was performed. Pre-specified subgroups was done. Sensitive analysis was done, including stillbirths and multiple importation for missing primary outcome data. And the statistical threshold taken was it is a two-sided analysis with a p-value of less than 0.05 is considered statistically significant, and software used was SAS version 9.4. So the results. So I already told the randomization was occurred from September 2018 to September 2024. 1641. 1641 newborns were randomized. 827 was randomized to FiO2 of 60% for resuscitation. 814 was randomized to receive FiO2 of 30% for resuscitation. 728 received intervention as randomized in 60% group. 99 did not receive intervention. 23 discharged as non-participating group. So out of this, 25 was lost to follow for a primary outcome due to no cranial imaging. So 728 was included in the primary analysis and the last. In 30% group, 814 was randomized to receive initial FiO2. 741 received intervention as randomized. Out of this, there was 4 stillbirth, 2 major congenital cardiac pulmonary abnormalities, 2 consent was withdrawn. So 21 was lost to follow a primary outcome due to no cranial imaging. So 741 was included in the primary analysis. Most newborns were singleton and born in Australia. In 73%, 58% were cesarean delivery, and 97% had some antenatal steroid exposure. The randomized intervention was received by 94% of the newborns. So these are the baseline demographic and baseline characteristics between both the maternal and newborn characteristics, which are balanced, and there was no any statistical significance. So the primary and secondary outcome from this trial, the primary outcome was certainly 96.9% of newborns, because 25 newborns was lost in the 60% group, and 21 was lost in the 30% group, and neuroimaging was performed in 96% of the newborns. So from the primary outcome in this trial, in comparison of 60% versus 30%, that is a death and brain injury by 36 weeks of gestation, there was no statistical significance which was achieved between the two groups, with an absolute risk difference of 0.84 and with a relative with adjusted relative risk of 0.98. So the primary outcome that did not gain the statistical significance between the two groups. Coming to the secondary outcome, there was a total death of 229 newborns, that is both in the 60% and 30% group, and most of this death was occurred due to cardiorespiratory failure, but it does not gain any statistical significance between the two groups. So comparing the exploratory brain injury outcomes, the ventriculomegaly, as you can see from this picture, the ventriculomegaly was higher in the 60% group compared to the 30% group. The rest of the brain injury outcomes that doesn't get statistical significance, that is IVH, parenchymal lesions, leukomalacia, Porens, epilepsy, or other brain injury. So only ventriculomegaly had a significant difference in exploratory outcomes. So rest the primary outcome and secondary outcome does not show a statistical difference between the two groups, that is 60% versus 30%. Next comes the exploratory outcomes, that is the change in SpO2, FiO2, and heart rate over the first 10 minutes of life and until admission to the NICU. So these are all the box and whisker plots showing the respiratory outcomes in relation with the FiO2 of 30% and 60% groups. So this is the 30% group and this is the 60% group. So these are the interquartile ranges with the horizontal line in the center of the box representing the 50% of the infants, and this is 25th percentile, this is the 75th percentile. So what has shown this box and whisker plot in this trial? So the neonates who are randomized to the 60% group, that is FiO2 of 60% group, and as we can see from this picture, the yellow one is the 30%, this blue one is the 30% is the yellow one, 60% is the blue one group. So the neonates who are randomized to the 60% group are achieved target oxygenation earlier. So as achieved this is SpO2, has achieved the target oxygenation earlier compared to the 30% group, and also they have less episodes of bradycardia, and less episodes of hypoxemia, indicating that there was a significant difference between the two groups, especially in the physiological aspects, mainly the hypoxemia, bradycardia, and the targeted oxygenation achieved earlier. But it does not get a statistical difference between the 30% and 60% group, indicating that the physiological changes will be responsible to the 60% effort for some time, rather than it can't able to predict out the outcomes. So next one is the exploratory outcomes. Again, the newborn status in the delivery room and an admission to the NICU. So delivery room outcomes, total of 575 newborns. That is both in the 60% 30% groups required increasing the FiO2 to 100% for registration. But there was no any statistical significance between the two groups in intubation, receiving chest compressions. But there was a significant statistical difference between the two groups. That is, receiving chest compression and received epinephrine was lesser in the 60% group compared to the 30% group. Rest and the oxygenation achieved was also earlier in the 60% group. That is, the 80 to 80% oxygen was earlier in the 60% group compared to the 30% group. Rest of the time to the first breath and ventilated status in NICU admission does not gain a statistical difference between the two groups. So this is an overall visual abstract of this trial. So thus initiating registration of extremely preterm newborn with higher level of fraction of inspired oxygen, that is 60%, reduce the risk of death or brain injury compared with lower 30%. So what this trial was added, there was no significant difference in the rate of death or brain injury between the two groups. There was no primary difference between the two groups in the primary outcome. So, discussion, this is the largest randomized control trial, randomized clinical trial to authors' knowledge to compare the delivery room registration of preterm infant with a higher FiO2 of 60% versus 30%, but they didn't find the significant difference between the two groups. So the absence in this difference between the two groups may be due to several factors. So what are all the factors? The separation in FiO2 between the groups may not have been large enough to produce the measurable differences in major outcomes such as death or brain injury. So the separation was not large enough, and the FiO2 limits were chosen to reflect the current guidance. So start with FiO2 of 30% and not to exceed 60%. So which is an important for the consent waiver process. And meta-analysis shown that restricting with FiO2 of less than or equal to 30% or more than equal to 60% produce measurable differences in the physiological parameters and clinical outcomes. So the 60%, 30% shown the differences in the physiological parameters and clinical outcomes. So the primary outcome did not differ between the two groups. So the trial provides important insight into the yearly physiological responses and the potential implications of final oxygen strategy, that is with 60% oxygen. So neonates who are receiving registration with the FiO2 of 60% has fewer episodes of hypoxia, bradycardia, and required less episodes of intensive resuscitations such as chest compression and epinephrine compared to the 30% group. So this difference suggests improved physiological stability in the FiO2 of 60% group during the first minute of life. So strengths and limitation of the study. So it is a little large sample size and high fidelity to randomized interventions and high hastenment of the primary outcome. Limitations, it did not include the FiO2 of 40%, which is frequently used in clinical practice, nor did it examine higher starting doses such as 100% FiO2. So it was also not powered to assess the impact of other concurrent delivery room interventions that can significantly influence the oxygenation, such as delayed cord clamping, fast and respiratory strategies, and use of different respiratory devices. So what this trial shown that the trial found no difference in survival without brain injury at 36 weeks corrected gestation age between the 60% and 30% group. So the infants receiving 60% oxygenation initially were less likely to experience early hypoxemia, bradycardia, required advanced resuscitation. So these findings lay a foundation for future trials to determine whether different initial FiO2 strategies, potentially including FiO2 of 100%, can improve survival and long-term outcomes. So before concluding, I will give a few points. The net motion trial, it is a network meta-analysis, which is a meta-analysis done on individual participating data, which was published in 2024. This trial has evaluated the initial registration of this preterm infant less than 32 weeks of gestation with three oxygen concentrations, that is 30%, 60%, 90%. And what they've shown was the neonate who were resuscitated with 100% oxygenation has less mortality compared to the other lower oxygenation use, that is 30% and 60%. Based on this, the NRP has brought out the changes in the recent 9th edition. What they've done was in the neonate for target oxygen concentration in registration of these preterm newborns, a neonate who are requiring registration at more than equal to more than 35 weeks, the registration can be started with a target oxygenation of 21%. So with neonate between 30 to 34 weeks, their oxygenation concentration for registration was 21 to 30%. Neonate who are less than 32 weeks of gestation who are requiring resuscitation at birth, the optimal oxygen concentration recommended was more than equal to 30%. Thank you.
Thank you, Dr. Anbarasan. Now I'll request the Wadia team to please take over. Till then, there are two comments from our respected Jayari sir. First, that the excellent presentation, and he had two comments. Did any unit change antibiotic therapy duration after the study published? Also, it will be interesting to find which the units who are part of the trial. What is their current practice now? I think we'll have to look into that, sir. And second comment from him regarding the early impedance. Mentioning Girisha that there was impedance were used in early 90s in the apnea monitors, but current technology is advancement with AI image getting captured while impedance electrodes are used. Cost and validation by most centers at multi-site study will be needed with trail head-to-head with ultrasound lab. Fully agreed, sir. Wadia team. Well, then, if anyone has any comments or any doubts, they can please comment.
Good morning, everyone. I'm Dr. Arunita, respected everyone. I'm Dr. Arunita. Is my audio hearable? Hello?
Yes, please go ahead.
Okay. I'm Dr. Arunita Devnath, neonatology fellow from Wadia Hospital, and my moderator for today is Dr. Sonal, consultant neonatology. I would like to present one latest research article of clinical relevance that has the potential impact on our neonatal practice. As we know, shock is a common and life-threatening problem in neonates, and sepsis and neonates with sepsis and vasoactive drugs are frequently required when fluid resuscitation fails. So in neonatal septic shock, our immediate goal is to normalize the BP. But does achieving a normal BP always mean adequate organ perfusion? Traditionally, dopamine most commonly used as a first-line inotrop in neonatal septic shock, despite limited high-quality neonatal evidence. Recent physiological studies.
Sorry to disturb you. Your slides are not moving.
Yes. Okay. Yeah. So the recent physiological studies suggest that dopamine and noradrenaline may have differing effects on organ perfusion, especially the cerebral circulation. So in this context, we have chosen this to review a 2025 RCT published in the Journal of Pediatrics, which compares noradrenaline and dopamine as first-line vasoactive agents in neonatal septic shock, with a special focus on cerebral oxygenation and acid-base outcomes. I will be presenting it in the form of a systematic concert format. So the overview, the design is prospective randomized double-blind control trial, and the population, participants included were neonates with fluid refractory septic shock, and randomization was done. Randomization was done in computer generated variable block randomization, 1:1 allocation to norepinephrine or dopamine, stratified by gestational age less than 35 weeks and more than 35 weeks. Allocation concealed, usually serially numbered opaque sealed envelopes were used. So why is this study important? Neonatal septic shock has high mortality. In few of the adult and pediatric data favors norepinephrine. So there is only limited neonatal RCT evidence. So there was a need to compare noradrenaline and versus dopamine as the first line agents in neonatal septic shock. So the study question was in neonates with fluid refractory septic shock, is norepinephrine superior to dopamine as a first line vasoactive agent? So the objectives, the PICOT, participants neonates with fluid refractory septic shock, hypotension, neonates with hypotension with more than or equal to 2 perfusion markers. Perfusion markers selected as urine output less than 0.5 ml per kg per hour, CRT more than 4 seconds, and serum lactate more than 5 millimoles per hour. Metabolic acidosis with base excess more than -5, and SPC flow less than 40 ml per kg per hour. Then the participants chosen were terms and preterms. Terms up until 28 day of life, and preterms until 40 weeks of post-gestational age. Total assessment was done, assessed neonates were 138. After exclusion criteria, it was randomized only for 80. In which norepinephrine was given in 41 babies and dopamine was given for 39 babies, analyzed by intention to treat. Then the intervention and comparator. Norepinephrine was given in the norepinephrine group. It was first the norepinephrine was diluted in 50 ml, 5% dextrose, started at 0.2 micrograms per kg per minute, started at 0.4 ml per hour. And in the dopamine group, dopamine was also diluted in 50 ml, 5% dextrose, started at 10 mics per kg per minute. This is also at 0.4 ml per hour. Then this was administered via central line, peripheral line used if central access was unavailable, and this was done in a central or dedicated standard NICU care in both groups was made available. Then outcomes, primary outcome was seen shock reversal at 30 minutes. Secondary outcome, time to reversal, vasoactive escalation, and use of steroids. Now the eligibility criteria, the inclusion criteria, all the neonates with fluid refractory shock, with a positive blood culture, with a positive septic screen, compatible clinical course as judged by the treating team, having received antibiotics for at least 5 days. Now the exclusion criteria was major anomalies, HI, prior inotropes used, surgical cases, parents who did not give any consent. Then methodology, it is double-blind, parallel groups, RCT, allocation was done into 1:1 ratio, and framework superiority. Setting, it was done in a tertiary NICU in North India, and duration of the study was 18 months. That was from February 2023 to July 2024. Written consent in local language before enrollment was done. Now randomization and blinding. Accordingly, randomization was done in computer-generated variable block randomization, and 1:1 allocation to norepinephrine and dopamine was done, and stratified by gestational age. Double blinding. Blinding was done. A study nurse was present who prepared the infusion, and syringes labeled as study vasopressors. Treating clinicians and outcome assessors were blinded, and norepinephrine and dopamine appeared identical and had similar titration rates as mentioned before, 0.4 ml per hour. So this was the main result in which during the study period, total assessed were 138, among which excluded were 58, and randomization was done for 80 babies. in which norepinephrine was given for 41 and dopamine 39. There was no loss to follow. Then the first table shows baseline characteristics of the included population. This purpose of this table was it shows both groups were comparable at baseline. Means it ensures successful randomization was done. First, in the characteristic group, as we see, there's demographic factors like gestational age, birth weight, male gender, outborn neonates. So both the groups had similar maturity and growth risk profiles. Means all the p values are coming more than 0.05. It is not statistically significant. Another perinatal factors in which we see antenatal steroids, PPRM on cesarean sections, there was no perinatal confounding affecting the shock severity. In sepsis profile, as we see, late onset sepsis and screen positive and culture positive, severity and the burden of the sepsis was comparable. Means both the groups has severity of the sepsis was almost equal. So we can compare it with the was comparative. Then after enrollment, we can see other associated neonatal factors like heart rate, blood pressure, SPC flow. Both the groups equally sick at shock onset. And lastly, the acid-base metabolic status like pH, BICA, base deficit, lactate, PCO2, both the groups had equally severe septic shock physiology. So interpreted as we interpret the baseline demographic, clinical, hemodynamic, biochemical characteristics well balanced between the norepinephrine and dopamine groups. So it indicates, this all are indicating that there is effective randomization. Next, among the enrolled neonates, 49% was taken, had means around 39 out of 80 had culture positive sepsis, among which 41 rest the remaining, in which 26 had a screen positive and 15 had clinical sepsis. So among which most commonly seen was gram-negative organisms, in which Klebsiella pneumoniae was the most common isolate, followed by Acinetobacter, then E. coli, Pseudomonas, cons, and MRSA. Okay, so the primary and the secondary outcomes from the RCT, this table compares the norepinephrine and dopamine as first-line vasoactive agent in neonatal fluid refractory septic shock. So the primary outcome, as already said, which was reversal of shock at 30 minutes of initiation of the vasoactive agent. So as we can see in the norepinephrine group, there was around 31% of shock reversal, and in dopamine 46% shock reversal, which is not statistically significant, but numerically, if we see, there was numerically dopamine looks better, means 46, it is more 15% more than norepinephrine group. This was explained by higher increase of BP following dopamine infusion in initial 30 minutes, which plateaued within hours due to initial action of dopamine via norepinephrine release, followed by depletion of the endogenous norepinephrine stores in with time. So this was the reason why dopamine had higher numerical chances of having higher chances of reversal in the first 30 minutes. Next components we can see the hypotension components of the primary outcome, hypotension, CRT, normal pulses, and warm peripheries. All these are not significant. So no one single clinical component showed any superiority of either of the two drugs. And the secondary outcome showing the second need for addition of any second vasoactive drug, need for any third vasoactive drug. All both the groups trigger escalations. No difference. There was statistically no any statistical significance in both the groups. And next, the adverse effect. As we see the adverse effects, most importantly, we can see the incidence of tachycardia more in dopamine group, which comes to 15%, and as compared to norepinephrine, that is only 2%. So dopamine causes significantly higher tachycardia as demonstrated, and other neonatal and also incidence of hyperglycemia. As we can see, it is not statistically significant. It is 24% in norepinephrine and dopamine group 34%. But in the after subgroup analysis, we are seeing that in dopamine group there was high incidence of hyperglycemia in more than 35 weeks of gestation age. Next, the major neonatal comorbidities like IVH, BPD, NEC, ROP. These are neither of the drug affected mortality or any major comorbidity. So overall, we can interpret norepinephrine and dopamine comparable efficacy in achieving shock reversal time of repeat, need for isolation and mortality. Dopamine is associated with higher incidence of tachycardia, suggesting less favorable safety profile. The next table is showing, now what is this table showing broadly? It is to compare how physiology, perfusion, acid-base status change over the time after starting. This is after initiation of the norepinephrine versus the dopamine. Now groups were noradrenaline and dopamine, and time points were assessed. Means first in the early 15 minutes, then 30 minutes again assessed, then intermediately 6 hours, then 24 hours. So these were the time intervals in which the assessment was done. So we can see in heart rate, blood pressures, that was similar in both the groups. Mean heart rate not statistically significant at any of the patient, but we have already found in the table number 2 that there was tachycardia present with dopamine, clinical tachycardia. So rest of the things in most important, we can see cerebral tissue perfusion. After the initiation of dopamine and norepinephrine, we can see 30 minutes and 6 hours, there's no clinical significance or no statistically significant data. Means both are comparable, but in at 24 hours of at 24 hours of starting the inotropes, we can see a relatively more p-value comes most p-value is significant. It is coming around in norepinephrine group 76% is showing good cerebral tissue perfusion as compared to dopamine, which is showing very less tissue perfusion. So norepinephrine significantly is higher than dopamine, which is also stating that dopamine associated with lower cerebral oxygenation, suggestive of worse cerebral perfusion and higher oxygen extraction. That is, dopamine compromised the cerebral oxygen delivery at 24 hours. So this is very important. So next is acid-base balances like pH, bicarb, and base deficits, as we see. At 6 hours and 24 hours, there was similar. In 6 hours, there was similar ratios. At 24 hours, overall, we can see the pH was a little higher in the norepinephrine as compared to dopamine, which was around 7.2, which was less. Dopamine was causing more acidosis at 24 hours. which is coming clinically, statistically significant. So, accordingly, in bicarb also we can see there is a low bicarb in cases of dopamine at 6 and 24 hours. So, possible explanation can be, as explained, was dopamine lowers the renal bicarb threshold by decreasing the activity of the apical sodium ion exchanges, causing acidosis and unfavorable effect on oxygenation, resulting in the lower cerebral tissue oxygen perfusion. So lastly, we can see lactates. Lactates, which is the marker of tissue perfusion, similar effects can be seen in norepinephrine and dopamine group. Means global tissue perfusion was comparable, but if we see the cerebral perfusion, that is comes lower in dopamine as compared to norepinephrine group. Lastly, the respiratory supports, MAP and FiO2, there is no differences seen and not statistically significant. So we can say that difference in the cerebral oxygenation were not due to higher oxygen ventilatory supports. So, a summary of the table 3, we can say similar effects can be seen in norepinephrine and dopamine group for blood pressure, systemic blood flow, lactate clearance, and oxygen ventilatory support. But as we see in dopamine, there are very disadvantages like decreased cerebral oxygenation perfusion at 24 hours, persistent metabolic acidosis, higher base deficits, higher PCO2 early on. Then and main norepinephrine advantages that we can see is better cerebral perfusion and better acid-base recovery, we can see. So discussion, this was a double-blind RCT comparable, compared norepinephrine and dopamine as first-line vasoactive agents in neonatal fluid refractory septic shock. The study found that both the drugs had comparable efficacy with no significant difference in shock reversal at 30 minutes, time to shock reversal, need for additional support or mortality. So although efficacy was similar, but dopamine associated with more adverse physiological effects like higher incidence of tachycardia, lower cerebral oxygen saturation, and worse metabolic acidosis at 24 hours. Norepinephrine had a better safety and physiological profile. It improved systemic vascular resistance without any excessive chronotropic effects like tachycardia. So the harms and was mainly tachycardia was more common, and with the dopamine, no increase in major morbidities between the two groups, and mortality was similar in both the two groups. Limitations of the study was it is a single center study. Only one hospital was selected in the tertiary hospital in North India. So there was a sample size, limited amount of samples as recorded. No eco-guided hemodynamic assessment was done, and no long-term neurodevelopmental follow-up as taken in. Can I notice the cerebral perfusion? So the long-term neurodevelopmental follow-ups were not done in this study. Now, applicability to Indian NICUs, it supports norepinephrine as
Can't hear you, Arunita.
I think you finished that one mostly, isn't it? So should we move to the next, because the time is very it's almost 9:30 now.
Sure, sir. I think we have lost her.
Yeah.
I will request the written first team to please take over.
Might just comment while I think Avinash is loading the slides. There was
Yes,
an
sir.
intrinsic bias, like see, dopamine 10 is not equivalent to 0.2 of norepinephrine. It's equivalent to 0.1. So starting dose of norepinephrine was very high. And so I don't know, like they should be head on, who should have been 10 versus 0.1 to starting dose, or they should have started with 5 mics versus 0.05. Anyway, it has not shown difference, but
Right, sir. And sir, also one thing, I had one query. Should we start NORAD without first ruling out cardiac dysfunction? Because we all know that NORAD will increase the afterload and will have
yeah,
a effect on the
yeah.
cardiac function. So I'm always very skeptical of using NORAD as first line without first confirming that there is no cardiac dysfunction.
Yeah, I mean, yes. I mean, it's still well done style, but I think there are a lot of biases. We can continue discussing it offline, but yeah.
Right, sir.
Yes. Okay, thanks. But well done, Wadia team.
Hello. Hello.
Do you
Am
not
I
have-
audible?
Yes, please go ahead.
Is screen visible, sir?
Yes.
Yes. Please start.
Good morning. I'm Dr. Avinash from Little Fun NICU, and moderator for this session is Dr. Kiran More, sir. So we have not got any specific system for the presentation. So we have decided to summarize the evidences that have changed our neonatology practice. So we have divided, for the sake of presentation, we have divided these interventions in prenatal, delivery room interventions, and postnatal interventions. So coming to prenatal interventions, so antenatal steroids remains the cornerstone for the neonatal practice. Recent Cochrane review confirms that steroids reduces the respiratory distress syndrome, intraventricular hemorrhage, as well as neonatal mortality. Antenatal magnesium sulfate given before preterm birth, less than 32 weeks of gestation, is associated with a reduced risk of cerebral palsy in surviving infants. Then coming to the total trial, that is a tracheal occlusion to accelerate the lung growth. It was the largest randomized study on fetoscopic endoluminal tracheal occlusion for isolated congenital diaphragmatic trial. This trial demonstrated that fetoscopic endoluminal tracheal occlusion significantly increases the survival to discharge in fetuses with severe congenital diaphragmatic hernia, with some studies showing increase from 15% to 40% survival. But procedure remains controversial and considered investigational in many settings due to variable long-term data and risk of prematurity. Moving to MOMS trial. So the MOMS trial was a randomized clinical trial comparing the prenatal repair versus the standard postnatal repair for the myelomeningocele. It showed that the prenatal surgery significantly reduced the need of CSF shunt placement and improved motor function and hindbrain herniation outcomes at 30 months of age. Although it carries a maternal and fetal risk such as a preterm birth, these results support prenatal surgery in selected cases. So this is a short video of prenatal repair of myelomeningocele.
So idea of including these two, that the follow-up outcomes were published this year for both the trials.
Yes. Then coming to the next trial, that is CHAP trial, that have demonstrated the active treatment of even mild chronic hypertension in pregnancy with the target goal of blood pressure of less than 140 by 90 millimeters of mercury, have reduced the preterm birth and preeclampsia without increasing adverse neonatal outcome. This supports the earlier treatment of maternal hypertension in pregnancy. Then there was a prolonged trial for 17-hydroxyprogesterone that have showed that it did not reduce the recurrent preterm birth compared with the placebo in a woman with prior spontaneous preterm birth, leading to withdrawal of progesterone approval for this indication. Then we have maternal RSV vaccination and monoclonal antibody in infants. Maternal immunization with RSV vaccine given at 32 to 36 weeks of gestation reduces the infant RSV hospitalizations in early life, supporting its use in pregnancy. Also, we know that long-acting monoclonal antibody, that is nirsevimab, has been shown in a clinical and real-world data to reduce the respiratory syncytial virus associated hospitalizations by significantly 69% or more in infants, which is a major preventive strategy in this world. Then in May 2025, we had first successful personalized CRISPR gene therapy, which was reported in an infant with fetal inherited disorder. So it was a case of carbamyl phosphate synthetase deficiency, and with the help of CRISPR gene editing therapy, the cure was possible. While it is not yet routine, this represents the significant shift towards the precision in genetic therapy in neonates. So coming to the delivery room interventions. So recent 2025 uh, American Heart Association and International Liaison Committee on Resuscitation emphasize that delayed cord clamping for at least 60 seconds for most term and preterm infants. Also, a priority on gentle stimulation before invasive interventions, strong team preparedness, and emphasize on the routine tracheal suction for the meconium. These updates aim to optimize the early cardiovascular and respiratory interventions. Coming to the postnatal care interventions, starting with the respiratory system. So the budesonide in babies, that is BIB trial, was a multicentric randomized clinical trial that have shown that early intratracheal budesonide added to the surfactant did not reduce bronchopulmonary dysplasia or death at 36 weeks of postmenstrual age compared to the surfactant alone. This trial was stopped early for the futility and showed similar rates of primary outcome in both groups. Then recently, the non-invasive HFOV was introduced. The current evidence suggests that mixed results for the non-HFOV versus the conventional CPAP, though CPAP remains the first line non-invasive therapy pending further data. Coming to the cardiovascular system, the recent Baby Oscar 2-year follow-up study was done for the PDA management, and long-term follow-up of PDA treatment showed that the routine early closure may not provide the neurodevelopmental benefits, supporting more selective approach to PDA management. Then coming to the recent studies on neonatal septic shock for the inotropes, as recently Wadia team have presented well. The trials comparing the dopamine and epinephrine and norepinephrine in neonates with septic shock found that there is no clear superior first line vasopressor.
Skip. Next.
Then coming to the atropine for the neonatal intubation, multicentric trials showed that adding atropine to premedication significantly reduced the bradycardia during neonatal intubation, improving the cardiovascular stability. Coming to GI system, the FEED-1 UK randomized control trial demonstrated that the stable moderate preterms, that is 30 to 34 weeks of gestation, can start with the full milk feeds early from day one, leading to fewer IV fluids and total parental nutrition needs without increase in necrotizing enterocolitis or length of stay. Recent studies also emphasize on the individual fortification of human milk to meet the individual metabolic and growth needs, moving away from one size fits to all feeding strategies. Then for the HI long-term outcomes, the extended follow-up after the therapeutic hypothermia was done, and it showed that the survivors may face late emerging cognitive and motor challenges at school age, highlighting the need for ongoing follow-up. Recently, we also have developed some early onset risk calculators, and use of these early onset sepsis risk calculators have dramatically reduced the unnecessary antibiotic exposure to neonates by almost 73% in newborns of more than 34 weeks of gestation, preserving the safety while minimizing the antibiotic use. Then coming to the screening part, the bond trial for the cord blood transfusion versus the adult blood transfusion have shown that it reduces the severe retinopathy of prematurity as well as the bronchopulmonary dysplasia, though further data is needed. Also, the recent anti-VEGF injections like ranibizumab have become the accepted adjuvant for the therapy of severe ROP alongside the laser, with ongoing research to refine the dosing and safety data. And recently, in 2025, expanded newborn screening program in New York included the metachromatic leukodystrophy as a part of newborn screening that have enabled early detection and intervention before the symptom onset. So key takeaways from this presentation are: early full feeding is safe in stable moderate preterm that have reduced the invasive lines. Early onset sepsis calculators reduce the antibiotic exposure while maintaining the safety. There is no clear best vasopressor in neonatal shock has emerged yet. Budesonide and surfactant does not reduce the bronchopulmonary dysplasia routinely, and prevention strategies needed innovation. Selective PDA management is preferred over automatic closure. Delayed cord clamping and gentle resuscitation remains the core delivery practice. Intubation safety improves with the atropine premedication, and long-term follow-up with HI is critical for identifying late deficits. In conclusion, neonatology continues to evolve through rigorous evidence. Thank you.
Thank you, Dr. Avinash. Very concise and information-loaded presentation. If you have any comments or any doubts from anyone, we can please have them.
Yeah, I think everyone did a good presentation in terms of a journal club. Good pattern for journal club was followed. And only thing, the time is always a problem. Yeah, and everyone wants to present. That's why we rushed into the presentation. I said we'll just quickly go through and summarize. But I think this is also a good approach. We thought it's like in that system's best of the change practices, we try to summarize.
Right.
So maybe we can have some presentation like that in every 3 months or 6 months also, you know.
Yes,
What are the best articles done in previous 6 months?
Right.
Yeah.
We'll do that.
And only take home. Yeah, something like that. Anyone else has any comments? Thank you.
Reasons were good. Yeah, I think what I just use the doses is 2.3 is a very high dose.
Yes, agree.
Even in the pediatric and ICUs. So,
yeah, starting point is also
dose we didn't know.
Yes. Very high dose to start.
Anyway, I think, but the overall.
Your voice is breaking a little bit.
Oh, the rest.
I think there's some network issue with SIRS network.
I think he was also commenting same about the doses of dopamine, norepinephrine being very high.
Yes, sir.
As we discussed earlier.
Yeah.
Sir,
So just one more point, I'm Dr. Sonal. So
Yes,
as
sir.
had been told that NE should be started after ruling out LV dysfunction and all that. So I think the major limitation of this study would be that no echocardiography was done for anything actually. So the good thing was on invasive BP only the things were monitored, and a lot of clinical thing like CRT and all were also there. But I think in the age of focus, echo could have really made the study excellent and given us some answer.
Yeah,
That was
they have
from
done
our point of view.
NIRS. They have done NIRS, but no echo, isn't it?
Yeah, so NIRS without echo seems like very incomplete, I feel.
Yeah, true. Very, you can agree. And there are a lot of confounders they must have done. Only thing that like details data a study has, I mean details, a lot of details have studied, but it's not very well structured study. I hope some data will come out from Wadia, from our observational study of norepi versus dopamine.
Yeah. We'll
Mila
share
study.
it.
So
Yes,
focus,
Nilas. Yeah.
even though focus was a limitation in this study, you need to look at the generalized applicability, because most of these units just walk out, go to the two-tier cities and all that, and there you will not find this. It becomes very difficult to get the focus done by then. So I think that the focus was not in either of the patients. So it is not that in both it was a confounded sort of, and it was equally distributed. So I think that shouldn't change the
Results should not be changed.
outcome or anything. The only thing is that, yes, if it was done, then probably it would have guided better.
Yes, totally agree.
And then what happens if then whether this vasopressor should be used or not, that will be the next question. So if you do the 2D echo and find that there is LV dysfunction, probably you will not use either of these. It will become an exclusion criteria for that.
In fact, that's how the study should be designed. Rule out LV dysfunction. There has to be a clear-cut evidence of sepsis, not only clinical suspect, because just on basis of clinical suspect, a lot of dilution of the sample will be there. Babies getting apneas often get inotropes and antibiotics. Preterm babies often, they can be confounders. So it should be a very clear-cut RCT. That's only a challenge, I think, in Indian scenarios also.
It becomes no efficacy trial and effectiveness trial. So that's how we know that's why when it comes to generalized applicability, I think we have to take whatever is possible. When it becomes, these studies become generalized applicable when they go out in the clinical practice. Yeah. Anyway, we get very less numbers. Our studies are pretty small. The sample sizes are like 40 in each group. If you look at the adult and especially adult studies, they will have hundreds of babies, hundreds of patients in each arm. So I think that also becomes an issue when it comes to neonatal trials or the pediatric trials.
Okay, thank you everyone. Thank you all the teams.
Right. Thank you, sir.
Great. Okay.
Next month topic will be decided by the little Ferns team, sir. So you can please put the message on the group so that we can.
I'll think about some good topic. Yeah, sure.
Right, sir.
Perfect. Thank you.
Thank you so much. Thank you, everyone.
Thank you.